get started just because I want them to get as mo much of you as possible. And so the first is just our introduction. So I'd like to go ahead and welcome everyone. Thank you so much for joining us for our Hope Cultural Training. We are in May. And it's hard to believe that it's almost summertime. But I have on the screen a picture of an aspen forest, and every one of the interesting things, if you don't know about forestry, and I'm a novice to this, but I did learn that every aspen in the forest is connected by a single root system, and they give life to one another. And I thought how beautiful that is. I mean, how much we could learn from nature. And I think that's one of the things I appreciate most in my journey with cultural training and with learning about Native Americans and how much um, they tap into nature and lessons learned from that. So I'd like you to think about just somebody, maybe you spent the weekend with someone that you were just really fortunate and happy and thankful to connect to, or maybe there's somebody in this group that you're just really thankful to be able to connect with them. But I would like you to drop into the chat your name and your organization and just one person or group that you're thankful to connect with. We're just so honored that there are so many people from so many different places that are joining us and really interested in learning more about Native American culture. Just keep those coming. Thank you. So many of you have seen this slide if you've been with us in the past, but this was designed for Intertribal Council of Michigan and just working with Native Americans and just the importance of how they have to navigate many things as they're going on their health journey. So we're thankful for this this beautiful depiction of that, and we're thankful for you all, the partners that are traveling with us on this journey. I might be able to advance my slide. Oh my goodness, we just talked about how this, okay, there we go. Acknowledgement and disclaimer. So this training series is funded through PCORI, which is Patient-Centered Outcomes Research Institute, and specifically for an engagement award. And one of their requirements is that we acknowledge and provide that the views and statements and opinions that are presented in this training are solely the responsibility of us as authors and do not necessarily represent the views of PCORI, its Board of Governors, or its methodology committee. Last month, Beth Seeloff, who is co-lead on this project, she did such a good job kicking us off and talking about how we need your help. And so with any kind of award or funding, we do have to show accountability of what is happening and how people are learning. And you guys really stepped up last month, and we increased the pre and post question findings. We are analyzing these each month, and we will be presenting this back to the group as a whole. But it's really encouraging just to see how, how much people are learning from the beginning of the session to the end. So Catherine will be dropping the poll in the chat, and you can go ahead and submit that. And then at the end, like when we get to the discussion section, that will be dropped in the chat as well. So please, we can only count your pre-post if you stay until that end, but understand if you do need to hop off. But thank you for those of you who are really providing that input for us. We greatly appreciate it.
Cynthia, I'm raising my actual hand because I
Mhm.
don't know how to do it in Zoom. But I just wanted to let everybody know I did launch that poll and it
Mhm.
should pop up as a secondary window. It won't be in the chat, but it will pop up on your screen. So thank you for your participation in the poll.
Thank you. And if it pops up on their screen and then they exit out like I just did, will it still be in the chat? I think it is, but I'm not sure. Um,
I
but I
can
think it
put a
does.
QR code in the chat. That sounds
Okay,
good.
so we're also moving on then to the continuing education credits. We do have CEUs and CMEs that are available through Corewell Health, Cloud CME. You do have to register for to have an account with Corewell Health West. But the important thing is to remember these numbers, 65978. And you that's today's code, and you text that to 844-420-1171. Catherine did drop that in the chat as well. But those numbers are needed. If you don't have your account set up, just save that number. And if, as long as you do it within the next, I think it's 12 hours, you can still claim the CME credit. And reach out to me or Paige or if you have any questions, and we'll help you with some of those behind the scenes troubleshooting. Dr. Anna Mikvam is our guest speaker, and he has no disclosures. And I am going to, so this is a responsibility of our CME, Cloud CME credit. We have to show the disclosures here. And so you are duly informed. And we're going to go on to the introduction where Dr. Anna Mikvam is going to go ahead and um, pull up his slides, but it is my great pleasure to introduce you to our guest speaker, Dr. Frank Anamikwam. He is a tribal citizen with the Little Traverse Bay Bands of Ottawa Indians. He's the medical director of the tribal clinic in Petoskey, and he's also a community assistant professor with family medicine at Michigan State University College of Human Medicine in Traverse City. He brings to us a wealth of knowledge. I remember when I met him for the first time, a little over 2 years ago, just how impressed I was with his humility and his knowledge and just his insight into the needs of Native American people. So it gives me a great pleasure and honor to introduce you to Dr. Anna Miklam. Thank you.
Ani Buju Banaswe Anamikwam was Albanese Indigenous Waganakasingo Dao Nini Dao Migize Dodem Anamatu wait to go into Benda Dagwas Mishkiki Nini and Dao. My name is Frank Anamikwam. My Anishinaabe name is Yellow Thunderbird, and I'm a citizen of the Little Traverse Bay Bands of Odawa Indians. We say Waganakasing. It denotes the land, the place of the crooked trees. So it's our ties to the land here, the tip here of northern Michigan. And my clan is the Eagle Clan. And I come from my lineage is to the Cross Village, which is north of Petoskey Harbor Springs. So if any of you have taken the ride along the tunnel of trees, I recognize some of my colleagues on here. I know they have. You take that 119 and you'll end up in Cross Village if you haven't done that. And it's really nice in the fall time. And I'm a family medicine physician, as Cynthia has shared, and also a community assistant professor with MSU through the Traverse City campus. I'm very humbled, very honored to join you all today. And I want to say miigwech to all of you for checking in where you're at. I know we have a lot of schedules, we have a lot of sacrifices. So I really appreciate your time and being here. And I hope all the mothers on the Zoom call and those not on the call had a great Mother's Day this past weekend. Again, no disclosures. I am invested in health and wellness of our Indigenous people. What we're going to touch upon today is tribal health systems. We're also going to touch a little bit on lived experience of providers supporting a tribal health system and how to best involve Native Americans in decision-making and discussion during cancer treatment. And I want to give a disclaimer here. I am one practicing physician among one tribe. And so I can speak to my experience. I am going to be very careful not to share in generalities because the experience might be different for another physician or provider in our office, even tribe to tribe. So Bindigin, come on in, welcome. Biskonyan, Mikizanan, put on your moccasins and we'll go on a little walk together. So I think it's fitting to start off in this way, and then we'll circle back. I think it's always important to circle back in whenever we're presenting or sharing storytelling, if you will. And you've probably seen this with some of my colleagues who have presented prior to me, and you'll probably see it again after. This is something that is shared among our people. It's become somewhat pan-Indianism, but it does have its roots to traditional, specific cultural beliefs to our people, the Anishinaabe people. And when you look at this, in simple, just a simple description, you see a circle with equal parts, four colors, right? Well, in our cultural teachings, it gets very detailed, and I appreciate our neighboring tribe in the UP, the Keweenaw Bay community. I'll share these slides so you'll be able to check on these links, and I encourage you to explore this website. They give a lot of teachings to, even those who are from the community can learn more about their culture and spirituality, and those who are not from the community can learn more so they could be culturally aware, culturally appreciative. And so if you look here in the east, and it's always with cardinal directions, the yellow. And then if you look at human life cycle, we come from this spirit world as a spirit, a baby. And then we go around clockwise. The red is the south. And then this is the way the sun travels. We have youth, emotion. We go here to the west. We have adult, physical being. And then we get here to the north and the white in the top here. And we have elder, mind. And so if you think about this from a healing perspective, Western medicine can be somewhat linear, right? In terms of disease progression, disease states, even life cycle. But in our teachings, it's circular. So when we come into this world, we come from the spirit world. And when we get to elder stage, if we get there, when we walk on, our spirit will leave our physical form and travel in those directions again. And there's varying time frames depending on your teachings. But after the travels, it'll go to the west and then where the sun sets and join the stars. So it goes back to the spirit world. And so I make that emphasis in that it's a 2D, two-dimensional symbol that we're looking at, but there's dimensions to this, 3 dimensions, fourth dimensions, if you will. So, with different realms, sky realm, underworld, and things like that. And overall in the center, there's balance. And so if you have a piece of this missing, think of a patient who cannot access care, right? They can't get their physical needs met. Maybe they're in pain. That's going to throw all these other things out of balance. Maybe they have really strong spiritual healing, and that might help with their pain a little bit. But we can't overlook one of these pieces because then we don't have a complete circle, right? Then we're not helping our patients achieve balance. So I was getting out with the realms. You see Turtle Island here as we look at the land as alive, and there's a whole creation story where the land was put on the turtle's back after a big flood, and Nanabuju was there. The animals and the muskrat ended up saving the people and bringing back the land. And then it grew to become North America. And if you even look at a map, you can kind of see the shape of a turtle. And the moon and the sun are there viewed as relatives, the grandmother and grandfather, respectively. And so looking at our land a different way, this is a GIF or video showing the signing of treaties. So as European contact came and then there was American expansion, you could see with each signing of treaty, 1.5 billion acres of land is ceded to the United States. And then the red that is left are the reservation areas. And so that is one thing I wanted to depict here in the perspective of land itself. It's not something that we view as ownership or to be owned. We are caretakers and stewards of the land. And getting a little bit more into just a context for all of this, and you've had some of this probably with the previous presenters. European colonial contact population was estimated around 8 to 112 million, and then it dropped to about 6 million over 150 years. I already pointed out the treaty era signing of 1.5 billion acres of land. With the formation of reservations, the federal government formed the Bureau of Indian Affairs. Its initial practices were subjugation and assimilation, and then now it's changed to promotion of tribe self-governance. And boarding school era is noted here with the time frame. We had one of the longest running boarding schools in the United States and Canada, and right here in Harbor Springs, so around the bay from Petoskey. And so I take care of some of my patients who they were first firsthand experience going through that boarding school, and they still carry those traumas to this day. On top of that, American Indian Alaska Natives were not citizens until 1924. Most states barred until 1960s. I think Utah was the last state to grant citizenship. Self-determination education, 1975, helped protect tribe governance, and then Religious Freedom Act in 1978. And prior to that, it was illegal to practice your culture and spirituality. And so a lot of people did not practice in public for fear of being targeted. And I pointed out there too in that pictures, we all know with the European contact, there was exposure to microbes, and that's a picture of smallpox there. And so there were many people who passed away before even meeting a European or American because they were exposed to microbes they did not have antibodies to. And there's a picture of Carlisle Boarding School in the middle, and then I believe that's President Coolidge with Osage chiefs when they signed the Citizenship Act in 1924. So following all that, I know it's really heavy, and I please take a moment if you need to care for yourself. And I don't want this presentation to come across as we're trying to blame or shame anyone. I also don't want to reopen wounds and scars, but it's just something that we need to acknowledge. And then in order for us to move forward and to grow and heal together, we have to acknowledge that. And historical traumas are also tied in with current traumas, also generational traumas that are passed on through lineage. And there's a move away from resilience. Many people will kind of place that label that, oh, natives are resilient. We are, but we're more than that. And I think when we speak from our perspectives, we take in the account of survivorship. And we have survived these traumas that our ancestors had faced and that our families currently face. And I think when we look at it with that lens, then we can really also emphasize the healing that needs to occur. On top of traumas, environment risk, and that we're concerned about, this is like Michigan, the Straits right there by Mackinac Bridge with risk for oil contamination. And we have a lot of PFAS, PFAS in some of our well systems in our area too. So trying to do a lot of work on that because there's newer studies showing that there's links to cancer-causing agents for those. Also sustainability, so food systems, housing, workforce, and health are all compounding factors. IHS just kind of showing a service area, and I'll kind of go big picture and zoom down to our community so you can get a little bit of understanding of our tribe specifically. The 3.7 million American Indian Alaska Natives in 2020 census, about 30% utilize IHS. So the remaining use either a tribe health system, which is not IHS owned or operated, and or they use an urban Indian health center, or they choose not to, or maybe there's other factors involved to not utilize those services and they use another health system. And 574 different tribes throughout our nation. That's not accounting for historical as well as state recognized communities. And then Bemidji area zooming in on the three states. And then you could see the different tribes represented. It's a little bit more diversity. When you zoom in on just our state, and thank you, Intertribal Council of Michigan, for this map. I think you guys had taken it down some years ago, so I wasn't able to find a new one. But I like this. It shows kind of by county where each tribe is located. And with given the location of Corwell, you're a little bit more closer proximity. And I believe you actually have Nottawasepi tribe runs the Urban Indian Health Center in Grand Rapids. So you could see our state spread here. There were communities more in the Detroit area that were forced removed to the plains. Many of our ancestors signed treaties so we could remain in place so we don't lose our connections to our homelands. And then going back again to, there's still some diversity, not as much if you look at all three, but just within the state, we have primarily Anishinaabe, so the first people, the good people, 5 Ojibwe, 3 Odawa, 4 Potawatomi tribes. So when you think of a tribe, if you haven't had much experience, and it's okay, some people, the first thing their mind goes to is a casino, but it's so much more than that. Casinos are a big part of tribe operation, but we do a lot with regards to other business ventures, getting into tech or agriculture, and then we also we have service lines as well through our government. and health being a big factor. And so this is getting more into our people. So another thing with regards to business ventures, when you think of our tribe, it may seem that our biggest asset is our economic ventures, but we're doing that for a reason. And from our community's perspective, so our biggest assets are our youth and our elders. So what can we do that's going to honor the past 7 generations and have an impact for the next 7 generations? And so a big part of that is maintaining ties to homeland. So you could see in this map on the right, the shade of our reservation tax agreement area also kind of covers our tribe jurisdiction for court and law enforcement. So it's the majority of Emmett County. You can see the dark spots speckled in, and those are actually our reservation and trust land areas. And so you could see traditionally a big expanse of our homeland kind of whittled down to these really small reservation areas. We got some of the islands also covered too. Let's see what time here. I'm going to pick up the pace just a little bit. So data epidemiology, I won't spend too much time on these because I'll share the slides, and I encourage you to check out the links and actually look at the reports because they get more into the social determinants of health. And I also emphasize this too is because each of our tribes are still working on internal data sets, and then we all have different EHRs, and we have a challenge with sharing data amongst each other. And you know, certainly data agreements would need to happen, but the 2 data sets that I shared did studies with tribal communities as well as urban, and so they have some of the most up-to-date data on mortality rates, as well as social determinants of health, cancer rates, and things like that. So I encourage you to please check those out and use them for a reference if you find them useful. And then so support tribe data and epidemiology was out of the Indian Healthcare Improvement Act, which was a part of the Patient Protection Affordable Care Act of 2012. And just to caution with the large data sets have a little more power, but the smaller data sets have undersampling and potentially underpowered for their stats. So we got to be really careful too, not to paint a broad stroke when we're looking at these data sets. It might look completely different when you actually look at just the tribe specifically at data sets. So there's the Great Lakes Intertribal Epidemiology Center, the tribes that they help with data reporting. And then this is just a demographic for Michigan. 2018 American Indian Alaskan Native population was about 53,000 for single race identified. If there was a multi-race identified, 147,000. 71% urban, 29% rural. So majority of our indigenous people live in an urban setting as opposed to rural. So that was something, as I was looking into data several years ago, that was news to me. And then the right plot here is age sex distribution. So Michigan has more of a square shape versus Minnesota, Wisconsin, more of a triangle shape. So they have projected more growth for their populations, while ours is an older population and kind of steadying and leveling out a little bit. All-cause mortality rates are higher for American Alaska Natives compared to white demographics. And you could see that by the different states on the left, 3 states combined, and then United States compared. And this was an alarming statistic. U.S. rate of preventable deaths per 100,000 for American Alaska Natives was double the national rate. And, you know, a lot of that has to factor in the traumas, but also social determinants of health and access to care, which I'll get to towards the end of the presentation. Specific causes for death: diseases of the heart, malignant neoplasms, cancers, and unintentional injuries being the third. And then we're kind of more in line with the United States. For Minnesota, Wisconsin, all 3, it's flipped. So they have malignant neoplasms for the top one versus disease of the heart. A big factor to that is delayed screening or not having access to care to get screening. And then there's also a lot of mistrust and stigma in institutions. And so trying to address that, to have patients feel more comfortable, meet them where they're at, make these screenings culturally adapted can really help. And I see one of my colleagues on here too, having patient health navigators are invaluable. We need to have them as part of our treatment teams because we get so busy in primary care, as well as our oncology colleagues get really busy as well. So having an additional team person to help coordinate is essential. Further breakdown, all 3 states, looking at other causes of mortality. Additional ones there. And then the Urban Indian Health Institute out of Seattle provided the data set for the urban population. And so there's the states and the cities that were involved. And then it shows population density too. So you see for our northern Michigan region about 4% of the population is indigenous compared to downstate, 2% or less. And then the counties involved, or counties represented. Top cause of mortality, you can see here for Detroit American Alaskan Natives compared to non-Hispanic white, that vascular disease followed by cancer, and then chronic lower respiratory diseases and unintentional injuries. So the top 4. It's flipped for non-Hispanic white relatives, where it's chronic lower respiratory diseases 4th, and then unintentional injuries 3rd. So this just shows you that these are areas to target when we're trying to address mortality. To address this health disparities, Indian Health Service was formed actually out of the Constitution and formally established out of DHHS in 1955. And I want to emphasize the mission, spiritual health. So it's really trying to culturally adapt and meet our patients where they're at, make sure that we're not overlooking that spiritual cultural aspect. And I think that's just a contrast to our Western medicine training, and it's gotten better over the years, but just with the emphasis on physical. And it wasn't until too long ago we added the head back to the body and started addressing mental health, behavioral health, and then expanding that to social issues. So funding is an important aspect for us to continue to do our work. So tribes are owned and operating their own health departments for the most part. There are some tribes that will rely on Indian Health Services for operating. Now, for funding, majority of tribes do rely on IHS budget sharing. And so the federal government will create a budget, exec department reviews every February, and then congressional review is followed after that. So there's potential for funding cuts as we're all experiencing just in general. And so that's something we've experienced over years and years of not really having an increase in funding for the care we provide. And this is GAO analysis. Shows the Medicare on the left here, 13,000 per recipient, Veteran Affairs 10,000, Medicaid 8,000, and Indian Health Services spending per user 4,000. And this is another way that it's presenting it in more of instead of a bar graph, a table format. Non-entitled programs versus entitled programs on the right, and you could see underfunded. So tribes will get creative. And so to supplement that funding, we do have the third-party billing that will help with regards to making up for lack of funding from IHS. And so gaming is one thing, although many tribes who have a gaming system, it's a lot to build and then also maintain that. And especially if people aren't gambling as much. And there's a whole aspect to that too, on how we feel in health about promoting healthy lifestyles. But then we also have gaming as our biggest venture. So that's why industry, tech, agriculture, health, we do have a pharmacy, which is our biggest revenue generator for our clinic, and can help us expand services. And our farm on the top right, that's a picture of our produce being sold at one of the local markets. And that's something where we can have an opportunity to get revenue for that, but then also feed our people healthy foods. I also wanted to share a little bit about tribe medical directors. So I shared a little bit about just my tribe, and we are one of 12 federally recognized, and there's also one urban in Detroit. And so it's a total of 13 clinic sites. And we did form 2 years ago, and I was so excited about this. And we meet quarterly. Nesweshkodewak Nagani Gabwijik Mishkiki Ninuk. It's a mouthful, but it essentially translates to three fires leading medicine people. They're like medical directors is basically what we were trying to say. But our Anishinaabe one is very descriptive. So it's getting a little bit more into description on who we are and what we're doing. And prior to the medical directors speaking and meeting 2 years ago, we didn't talk at all. And so it was quite a shock to me when I moved from residency. I went to Sparrow MSU program in Lansing for family med, and I went right after. Took a couple of days off, went right into work and talking to the medical director that was here at the time, my second cousin from our tribe. And I said, "Have you ever talked with any of the tribes?" He goes, "We have so much of our own stuff we're trying to focus on that, I don't have time to talk with other groups." And I was like, "Oh my gosh!" So it was a shock for me. So after 2 years, we reached out, and then I became medical director, and we started doing more intertribal work. So not just focusing on our tribe, because what we're trying to get at here is sharing in best practice, right? And so if we're operating in silos, we can't get to that. And then, potentially can lead to more partnerships and resource sharing. And then I also want to emphasize too that the thing that we're trying to improve is our indigenous health systems. It's more than just our one tribe focusing on our health, or maybe a couple of neighboring tribes working together. It's how can we help improve the health systems across the state of Michigan for our indigenous people. And then getting a little more detail into our tribe clinic, that's a picture of it there. It still looks the same. I think it's a little dated picture. You can see by the vehicles there. It started in 2000, 4,600 plus tribe citizens, about 2,200 patients. And there's 5 providers total here. And we have 2 family med, 1 pediatrician, and a couple advanced practicing providers. We do family medicine, newborns, geriatrics, and telepsych, integrated care. We do not do obstetrics. And then we also have, that's just the clinic piece, the clinic department within this building. On site, we have many other services. So we have behavioral health, dental, pharmacy, community health. And community health does a lot of our assistance with regards to community outreach and engagement, helping with coordinating our annual health fair, and where we can really emphasize cancer screenings and preventions. And just to highlight one of the success stories over the span of 2-3 years with having a patient health navigator, we bumped our colon cancer screening rates from about 59 or about 50% to 70%. So 19-20% jump in our cancer screening rates. So we're so grateful to really have this space where we can have, for those outside of here, an FQHC-like setup. We have multiple services. We can do collaborative care and trying to work towards integrative care, although time and space makes that challenging, but really try to work towards integrative, holistic approaches for our people. And there's the Western medicine capsules, there's and some medications, in contrast to our traditional healing. And that's one service out of our behavioral health department that we're very proud of. And we have a traditional healer that comes 2 days out of the month. So you think about that. He's booked when he comes. Say he has patients from when he starts till he ends, and sometimes missing lunch. And then he does community engagement work outside of that. But there's a demand for it and not enough supply. And so a lot of our traditional healers will travel to each of the individual tribes and then share their knowledge and teachings and their practices. And so plant-based medicine is also used in our clinic. And I should rephrase that, in our health department. So that's one aspect we don't have fully integrated, is our collaborative integrative work with traditional healers. So then they're aware of, say, a patient that might have chronic kidney disease or liver disease, and then they're prescribing a plant-based medicine while we have them on medicines as well. So that's something where if we identify some patient, we will share that concern with the traditional healer. And then we ask them too, if they're going to put them on a plant, a tea, or if it's a salve or something, to please let us know, just so we can make sure it's a safe treatment regimen for our patients. And it wouldn't be our place as Western trained physicians to tell a traditional healer what to do and vice versa. It's how can we work collaboratively so the patient can make sure they're not taking too much where it's going to harm their systems. Another thing to point out here is our traditional foods. That's also medicine. So that's a cultural belief that and perspective that many of our people share. And so wild rice, gigun is fish, wild rice, manoman, minan are berries. There's a couple other berries in there. And then our um, mandam and bindam and kusmanan, so our corn bean squash soups. And then the Indian taco is not, it's become traditional. It's not traditional because of the flour cooked in oil and grease to make the fry bread. So it was a commodity food. It was provisions given by the military forts to our ancestors, and it's become a staple, if you will, a traditional food over time. And and so I always put that one on there for contrast, but that's our traditional foods. And I really appreciate the DHHS working with IHS and USDA on making this native MyPlate. So it's an adaptation of the MyPlate. But it's emphasizing traditional foods, and there's a couple variations out there. Um, and so people can eat from what their families currently eat and what their ancestors ate. And there's no dairy on here because our ancestors did not have access to dairy. You can see water in its place. And then switching gears a little bit from food, I also wanted to share and highlight one of our traditional medicines. We have four kind of our foundation medicines, and there's so much more when you start getting into traditional work that uh, that many of our Ninandwe, Zijik, the traditional healers, they have just expansive knowledge, 300 plus plants that you can be used several different ways. So you could see how the knowledge can just quickly grow. But many of our people, when we tried to, instill cultural values and practice in home so they can have a place connected, they can have access to sema or tobacco, if they can have access to sweetgrass, cedar, and sage. And with those, they can use them to pray. And for our non-Indigenous colleagues or those who are on the call that don't have much experience with our communities, it's you can use commercial tobacco. And so when you may have heard of an Indigenous person using tobacco to pray, they're not a lot of times they're not smoking it. They're holding it in their hand and they're offering it to maybe it's a special place or it's a sacred place for them and their family, water to the ground or to rocks to fire. And then the tobacco will carry the prayers to the creator, to the spirit helpers to help them with healing that they may be asking for their families even. And there's two different types, so the Nicotana rustica and Nicotana tabacum. So there's a difference in the two, and the tobacco has been modified, and there's also additives. And so there are times when tobacco is brought to the mouth, but it's not inhaled, and that's through ceremony and smoking through a ceremonial pipe. And so that's something to just be aware of, is that your patients may be using tobacco. So if you counsel on tobacco use, you can't just do a catch-all and say don't use any tobacco, because it might be their cultural practice to use it in a cultural way. So as opposed to cigarettes, cigars, chews, and hookahs. And so with switching the messaging is, you might have seen this one: value our tradition, keep tobacco sacred. And I've seen the other one out there, traditional use, not abuse. And it's just emphasizing going back to how our ancestors used tobacco versus how many of our people, because of the influence from American society, use it today. And then they develop the addiction to nicotine, and they have the impacts from the other additives. Another clinic that we opened for our tribe is Crooked Tree Wellness Clinic. It opened in January 2023. And they service Medicaid recipients only. They do not offer OB. They have newborn to geriatric for those in that Medicaid recipient age, and then psychiatric, behavioral health, and a pharmacy. They just opened earlier this year. So they're expanding their services with that potential revenue generating service there. They have 3 providers. They're all advanced practicing providers, and they have a medical director that oversees and works with them all. But it's just been a great opportunity for our Indigenous as well as our non-Indigenous relatives in the community can access care there. And we realize that is a huge need. There are many clinics in our area, primary care and specialty care that will set caps on Medicaid that they receive because of the reimbursement so low. But we're very fortunate to get a pretty good reimbursement for a tribe health clinic from Medicaid, and that helps us to be able to sustain programs and grow them. So that's why we have 100% Medicaid cap at this clinic. And actually, if you have commercial insurance for Medicare, currently you can't be seen at this clinic. It's only for those recipients of Medicaid. Another organization that is supportive of American Indian physicians is the Association of American Indian Physicians. Came out of Oklahoma, founded in 1977. There were 14 physicians at the time. I want to highlight their mission. So advancing representation essentially of our indigenous people in medicine and balance of mind, body, spirit again. So you see that spirit aspect is pulled in. They have some national conferences throughout the year, as well as a cross-cultural medicine workshop where they'll have traditional healers and Western trained providers do presentations and share in the ways that they integrate their care. There's been a decline in representation in medical schools this is a 2018 MedEd report, AMA MedEd report. And so trying to have representation so we can have concordance, right? And we just want to emphasize inclusion. So we have majority of our staff in our clinic are non-Indigenous that provide service. And there are a smaller percentage of us that are either from this tribe or a neighboring tribe. And so it's important to have concordance where you have someone from that community to come back and be trained and provide service because their understanding of the cultural nuances as well as the diversity and the variance in spirituality practices. But that doesn't mean that a non-Indigenous person who is coming with humility and intent and they're open to learning and our patients and their families and our community are our biggest teachers, right? And so but the concordance helps. And so we want to make sure we have representation, but we're not opposed to having non-Indigenous relatives come and help as well. And to get into the numbers a little bit, this was a 2020, there was about 5.7 million American Indian Alaska Native people for multiracial. And so this was different than the stat compared earlier, which I don't think it was a full red census. But out of that number, 3,400 are physicians, so 0.065% of the total population. And then you compare that to the total workforce, 0.4% of the total physician workforce. And so there's just the numbers don't align there in our representation. And you look at the population density map I shared earlier, 4% of the population being Indigenous in Emmett County. We have certainly a underrepresentation in medicine. And then you may, for oncology colleagues on the call, you may even look across your field and see that there might not be that much representation and how can we recruit and retain diverse and representation of our communities we service. So ways to do that, and I should change this, it's pathway programs versus pipeline. And so University of North Dakota, University of Minnesota have some long-standing ones. There's also some collective schools out of the Four Corners. Those medical schools have some pathway programs. For MSU, they created the Great Lakes Pre-Admission, or they have a pathway program as well, but they also offer pre-admission workshops. And the MSU pathway program started about 7+ years ago. AAIP, the Association of American Indian Physicians, also offers pre-admission workshops to coach those who are interested in healthcare on a pathway and how to get there. And then another JAMA article supporting the boosting of the ranks of American Alaska Natives in medicine. And so to highlight more specifically the MSU College of Human Medicine Indigenous Peoples Pathway Program, and it's based out of the Rural Health Pathway Program. We have a 2-week elective for students in their 3rd and 4th year to rotate at our clinic. And they get to work with not just our clinic team, but also work with our cultural advisors and traditional healer to see how that care is provided. The students have just really enjoyed it. And a couple of our students here, when they came up and rotated, and they plan to go back to their tribes and communities after they're done with medicine. or their medical training. Another organization here, kind of following in that vein. So expanding or building upon the student pathway program. There's been a movement with the American Indian Medical Education Strategies Alliance, AIMS Alliance for short. And this organization is national, and they have the partners you see outlined here, with tribes, academic teaching institutions, medical institutions, and then teaching hospitals. And then there's the state representation there. MSU CHM was one of the first members to join, and the focus is on GME. And you could see here with this graph, the decline in physicians for the different areas for Indian Health Service. And then life expectancy also kind of correlates with that too. And so for our Bemidji area, right, for IHS, 60% select physician vacancy rates in Indian Health Service facilities. When the tribe medical directors, we met for the first time with the Bemidji IHS director back in April, and she shared that there's been some improvement. So it's not quite 60% anymore, but still, there's still a gap. And, a big part of that is not having the funding to train physicians in tribe sites or IHS or urban sites as well. And so if we could secure funding, then you can have a physician trained in that community. They're more likely to stay after residency. And I know if physicians on the call can attest to that, if how many of you have stayed in the area after the residency program because you got to know the system, got to know the hospital, maybe you planted roots in the area, family, and things like that. So when that happens, if there are Indigenous people that leave their community to go train, many Indigenous people don't go back to their community to provide service. They stay in the area because of many, many factors. So how can we build training programs for residency in tribe, Indian Health Service, and urban community sites? And so advocacy is a big thing. This is myself as well as the recently retired Jerry Kooyman. He's Assistant Dean for External Relations at MSU CHM, and he has a successor that has taken his spot. He's still involved with advocacy, and we went to Capitol Hill last year in the summer to advocate for the funding to secure these training sites. So it was a great experience. And then this is something brand new. McLaren Flint, they have a rural training program out of Petoskey for family medicine, and they're going to be graduating their first graduate this summer. So it's very, very exciting. And so MSU tapped the tribe, and then also being a partner with the Michigan Docs, it's a funding source, a state funding source with federal match dollars for 2 residency positions. And so MSU asked if we would be interested. I talked with tribe leadership and our tribe chair, our government, our tribe chief's office, and they said, "Yeah, this sounds like a great opportunity." And so we're able to secure these partnerships. So we'll be starting this summer our very first 2 residents, and they'll be doing their first year in Flint, and then their second and third year working at our tribe in our clinic, and this will be their core community clinic. And with the hopes that they'd like to stay on after training, or at least stay in the area. Maybe they choose to join McLaren or another group, but they're still in the area providing service. They join McLaren, do inpatient. They'll see our patients there. And so a lot of amazing opportunities that are just anticipating to come from this beautiful partnership. And so to circle it back around, I talked about some opportunities, some pathways, and be kind of wrapping up here in the next couple of minutes, but just want to emphasize again the importance of culturally adapting these things that we're doing: clinical care, academic medicine, research, making sure that research is community engaged and done with intention and transparency, and the information goes back to the community to help the community with quality improvement and growth. And so we're going to just end with that. And I also wanted to mention understanding, so Gikenda. So I hope we were able to get some understanding through our talk. And G-money. We're all in the canoe, right? And so we all have to take a paddle and help move forward or different directions. So it kind of ties in with Cynthia's presentation at the start with the boat or the canoe. It made me think of that. And you with learning the landscape, right? Learning about culture. And if you make a wrong turn, you adjust the paddles, right? You can maneuver back and try to revisit some things, and then get back on course. And there's usually a person too that sits in the back traditionally, and with our canoe, our people who did canoeing a long time ago. We do canoeing still today, but not as much because we have cars and planes and other things. But at this, back when our ancestors were primarily here, the water systems were our highways, right? And going across the Great Lakes. So a point person is usually in the back, the person that's leading, and they're steering and they're calling out directions to go. And so I always love this analogy that when we're all in this canoe together, we're all helping. There is a person at times that takes the lead, and that position can be rotated, and then we're all leading together. I want to thank Corewell Health as well as the Intertribal Council of Michigan for this time, and I hope we were able to expand everyone's knowledge on those talking points from the beginning, the agenda. And I also want to thank colleagues in our Hope Project who had presented before me and those who are coming after me. I think I'm somewhere in the middle, and we're going to be doing a panel in October, so I'm really looking forward to that. I want to thank my tribe, Wabanaki as well as all our Anishinaabe of Michigan and the Great Lakes, and just always humbled and honored to represent our people where I'm at. And then while I'm leading and as I grow, to help lift up others as I'm rising. And I say that humbly. I can't rise without those above me helping to lift me up. So, and I also want to thank Michigan State University College of Human Medicine for all the support and really investing in us as a partner in the future of our medical education, but our people, the health of our people. And I want to say miigwech to all of you. Chimiigwech Nimkinagoya. Wajimana, any questions? And there's where we're going to embark from. We're going to embark from Arch Rock, Mackinac. So,
What a beautiful presentation. Thank you so much, Dr. Anna I know Laura, and possibly Beth, if she's on, are monitoring the chat. So I want to direct the conversation to them. But could you just address very quickly, are there prescription barriers for your tribal for your people that we need to be aware of as healthcare providers? That's one question people had. And then another question was that I got from some of the providers was just some tips for how we can better communicate. I mean, I think you gave us a lot of really good ideas, but those are two things that that they were curious about.
Yeah, certainly. So the first question, prescription barriers. So we do the 340B program for our tribe pharmacy, and it's pretty expansive formulary. So if we can't get something, we can usually get it next day. And if we don't have it in stock, there are some things where it's just not on formulary, and so we try to find the best alternative for that. The other things with regards to prescription writing, one of our partners for helping us to build pharmacy, University of Michigan, they have a discount pharmacy program, especially for chemotherapy medications. And sorry, I'm drawing a blank on the name of the program, but that is something that we looked into in the past. And our pharmacist has connections with them, and so they were able to bring it to our tribe's attention. And I don't think we've utilized it, but it can be a resource if any of our oncology partners are interested, if they have an Indigenous person. And actually, I don't think it's for just Indigenous people. I think it's for anyone who might have, say, an income a barrier to be able to access the expensive chemotherapy medicines. Then the second question was about, I guess more of a formal way for interacting with Indigenous people, correct? So I actually have a fold out. It's a little dated, but I think it'll still work. It's a PDF, and so I'll share it with Cynthia if you can get it posted. I'll see if I could even pull it up here while we're talking. But it's made by DHHS and Indian Health Services, and it's a cultural uh, cultural card, if you will.
Mhm.
And it gives kind of just a general overview of cultural differences and then how to like approach different situations and things to be mindful of with regards to culture, spirituality, and things like that.
Mhm.
Um, there it is. Thank you, Laura. Yes, X, yes, prescription.org. That is that program. Thank you for sharing that. So while I'm still kind of reflecting on that answer, I'll try to find that and share that card in the chat while we're talking here. It might be as a
Sounds
PDF,
good.
so I don't know if I can get a link to it. Any
Thank
other
you.
questions? I did want to highlight something, and while people are thinking of questions, so I had a little reminder in the one of my slides, and I overlooked it. So back in 2022, the University of Michigan Rural Cancer Institute reached out to us, and it was connections through Intertribal Council of Michigan. And we did two men's health events. And we had that particular group within our population that had some of the lowest screening rates for cancers. And so we're kind of emphasizing lung cancer screenings, prostate cancer screenings, colon cancer screenings. And we did it was felt like a day, but it was like most of the day event. So we started with a breakfast, and then there was some I think more people came for the door prizes because we had hunting and fishing gear and so they can get a ticket and there were drawings throughout it. And so we made it kind of fun. But then I presented as well as our traditional healer, they presented. And so and I share a perspective on like, Western train, kind of trying to culturally adapt it too for just to kind of make them aware of why are we doing these screenings? And, because there's a lot of stigma, especially with colonoscopies and prostate exams. Men may have been carrying trauma. And so trying to really approach it in a soft way and kind of, really break that stigma and make it something that is, it's a as safe as it can be medical procedure, and it's important to detect something before it becomes cancer, right? And then we did some discussions and kind of answered some questions. The traditional healer spoke about kind of the way they approach with working with a patient who has cancer, and then we kind of wrapped it up with some more Q&A and they got some prizes. But it was interesting because we had our team there also getting people scheduled if they were due for their screening rates. And we had a little bump in our screening rates for each of those events. And we had 16 men for our first event, and we had about 30, almost 40 for our second event later in that fall. So we had a spring and a fall one. And it was just a really wonderful experience to engage the community in that way and try to do kind of a group medical education experience. So that's just something to think about for those out there. And it's we might question kind of like how do we approach working with an indigenous community if we have an indigenous patient in front of us. A lot of times just being humble and asking, right? And just let them know, hey, I don't know about that. Would you mind sharing? And sometimes they'll say no because there's protocols with learning some of the knowledge and information, but a lot of times they're pretty open to sharing, right? And so many of our tribes have websites too. So I encourage you, if you have a local and neighboring tribe or if you have someone from an indigenous community, you can research them and get to know a little bit more about their cultural practices, their spirituality, what are their services that their community offers, and is it something that you're identifying that they're having a social determinant of health or an access issue to something, maybe it's transportation, whatever it may be, and you could check the tribe site to see if they offer that service or connect them if they're not already. So I just wanted to share that.
Emily, you can ask your question and then I'll read the one in the chat.
Thanks. I just wanted to comment on what you just shared and that men's screening event. I had the opportunity to attend, and that still really resonates with me. And I think one thing I wanted to share with this group was some of the discussions by individuals who were supporting the event. So community members who were making the lunch or doing other aspects that were really supporting the event, how every individual that I was able to meet that day had been impacted by cancer, and the discussions of experiences that they had within the healthcare system and really feeling like they were experiencing biases in their own experiences. And I think, just from that perspective, I'm so grateful for this event and this series, but it really, for me, was compelling, and I won't forget those stories, and how maybe they weren't supported in their cancer journey the way they should have been. And so I wanted to indicate, like, I thought it was so wonderful with the screening and increasing awareness, but it also was wonderful to experience that learning and think about how we can be better. And so I just wanted to comment and share that related to the screening event.
Yeah, thank you, Dr. Mackler, and thank you for joining, because I know you helped to cook and serve serve food that day too. So yeah, it was
Yeah.
just, when we think about cancer, right? And we think about a lot of the health conditions our individual patients, our individual people, relatives face. And it impacts more than just them. It's their family, it's the community as well. And so it was nice to have a community approach with that. It's something outside of the exam room, and that is a safe, sacred space, right? That clinic exam room. You have trust that you instill in one another, and you're sharing deep aspects that patient's sharing deep aspects of their life and what really means to them, matters, and their values. And to have that blow, maybe they're carrying those other traumas we talked about earlier, and then they get the cancer diagnosis, and it just really hits them so hard, hits the family. So then, getting creative and with them being comfortable in sharing, and we had a lot of men there that didn't share their experience, but there were those who did and share their stories. It can help others heal, and that's what I really appreciate too. You saying that, Emily, and our community working with our partners to do that is provide that opportunity and space for our community to come and heal.
Okay, there's one question in the chat, and it's would be curious to know more about how the patient health navigator was engaged, and was this a specific intervention initiated through prior work/research? Might it be applied to other at-risk communities? Does this work best for a specific initiative, as you had mentioned, the colon cancer screening?
No, great question. And again, that came as a result of partnership too with Intertribal Council of Michigan, as well as their partnerships with the Michigan Public Health Institute out of Okemos, Michigan. And so they had a team come and help our tribe look at our workflows. And so we identified several areas in our workflows where the patient would come in and get the screening test ordered, but then there was just a delay in getting it done. There was a delay in having the results get back to the provider team. And so with the patient health navigator, that was the designated person to explore. We tweaked workflows. We had the huge flow chart. You all are familiar with those, right, too, with your organizations. We tweaked some of the workflows and had that person incorporated into the workflow. And we're able to support the patient, address what access issues they may have had, address barriers, and then they were able to get that test done. Then, working with our medical records team, they were able to track down the report timely. Because sometimes, and I don't know, I find this more because our residency program where I trained was integrated in Sparrow Health System. With our tribe, we don't share an EHR. And so it's really hard to know when someone gets the test done and to get the results timely. So that patient health navigator is then the one to see, is it in the chart? Is it in the chart? Have they faxed it? If not, a week or two time frame after they get it done, they jump on, they call the facility, or they log on to McLaren Cerner and pull the report. And so those are some of the ways that we tweaked for colon cancer screenings. We also did it for the other cancer screenings we do in our office as well. Tracking down mammograms, getting the patients to come in to do their women's health exams, and tracking down the Pap smear results, the cervical cancer screenings, and then with breast, I already mentioned breast health. With prostate, we tend to screen a little bit more, I feel, than I did at the residency program. We do screen with the PSAs more frequently And I'll do the individual counseling, right? It has to be shared decision making. It may not apply for every Native male to get a prostate level checked because we know the evidence is mixed out there, right? But I do find that we're screening a little bit more than I did downstate with that lab. And we actually have, from my small patient panel I see here, I have about the same size as the patient panel I've seen in residency, but I had quite a few males with prostate cancer, and there are some that passed away within the 4 years I've been here, and there are several who are in remission, because they caught it early. But it is something I feel, and I don't have the numbers and the data to share accurately, but just reflecting on my experience working here clinically, I have seen more of it than I have in my residency training. Yeah, so that patient health navigator helps with all of those big areas, not just colon cancer screenings. And could it be applied? It's interesting. Could it be applied to, say, COPD? Your panel that has that, or congestive heart failure. You could utilize a patient health navigator in those areas as well to help with care management, care coordination.
Yeah, I'm thinking on this call, Dr. Anna McClellan, and the people, the experts that are in this place, just how much we could, if we collaborate and work together, how much of an impact we could make across the state of Michigan. And, figuring out, if health systems could even afford to support some Native American, people that were those navigators for the communities, in all of the community hospitals. I mean, how cool that would be. I think you can all agree that Dr. Anna Miklam gave us a lot of things to think about and a lot of ideas that we could take forward. And that's just so exciting to see how this is going to change and improve just our knowledge, but most importantly, the patients that we see that come across our path as we're caring for them with cancer. So thank you for your part, Dr. Anna McClellan, in this. Thank you to all of you, the cultural training leadership team. I think Catherine and Laura and Beth, and I thank you, Dr. Anna McClellan, that you're a consultant along with Dr. Mary Isaacson. I mean, it just does, like you said, your last slide, it takes a team. It takes people working together, getting in the same boat and being willing to travel alongside each other. So thank you for that. It was well done.
Miigwech, thank you.
Thank you so much.
Mhm.
Hope everyone has a great afternoon.
Thank you for all your great work, everyone.